I believe that everyone deserves the right and opportunity to get the best care possible. And I believe that people who have socioeconomic and other barriers need not be prevented from getting that care.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Chyke Doubeni. Chyke is a family doctor and the Chief Health Equity Officer of the Ohio State Wexner Medical Center and Associate Director for Diversity, Equity, and Inclusion for the Comprehensive Cancer Center and the James, providing access to better educational, screening, and treatment options to underserved populations here in Columbus and throughout all of Ohio is one of the major goals of the James, and Chyke will fill us in on some of the many current programs, why they're important, and how they save lives, and what's next. Welcome to the podcast.
Well, thank you so much for having me.
Yeah, we have a lot of ground to cover, and I thought the best way to start is talk a little bit about your role as Chief Health Equity Officer and Associate Director for DEI at the James.
So, in addition to my role as Chief Health Equity Officer and Associate Director for Diversity, Equity, and Inclusion for the Plan to Enhance Diversity, as it's called, for the Comprehensive Cancer Center, I am also a researcher, and I believe a national leader in the area of screening, effectiveness, and how you deliver screening to people, with a very strong interest in addressing health inequities. So the role that I have enables me and other leaders at the Wexner Medical Center to design processes to allow us to do outreach to communities and also ensure that the patients who come to us at the Wexner Medical Center and the James receive the best care possible anywhere in the world. And so, for instance, one of the programs we've developed and have rolled out is to screen for social determinants of health across all adults who are admitted to the Wexner Medical Center.
Oh, you're not screening for a medical issue, you're screening for diversity and if they have any problems getting medical health care.
That is correct. So keep in mind that when we talk about social determinants of health, it's a fairly broad thing in the sense that it also involves getting people access to care and the quality of care they receive. Now, in the context of the screening for social determinants of health, as we well know, social factors are a major contributor to poor health outcomes, especially for our underserved communities. And so understanding and addressing those barriers to receiving medical care is crucial or paramount to ensuring that everyone gets the best care they deserve here and anywhere in the world. This includes cancer, right? So for them to get screening for cancer and prevent cancer, they have to have the ability to get access to those cancer screening facilities and the tests.
Mammograms, colonoscopies.
Exactly. And so one of the programs that we are working to amplify is how we get people transportation to care, such as colonoscopy, within our services.
Okay, I think I understand. So people, you sort of evaluate patients, and if they do have issues of transportation, healthcare, financial, just access, they could live 200 miles away. You determine who these people are and take special steps to make sure that they get the screening.
That's correct. I mean, we work hard to refer them to services in the community, and sometimes we can provide those support directly. Have we solved the problem completely? No. Are we working to solve it? Yes, bet you we are.
Wow. So, and then also you said your research is on screening. It's not a specific research on like how to make mammograms or colonoscopies better. It's a bigger picture humanity research and how to get people the education and two screenings that they need. Is that correct? Am I close?
Well, let me try to describe my body of work just a little bit. Much of my work has been around colon cancer screening, so in two specific areas. One is, are the screening tests effective? So we're talking about screening tests and whether they can prevent death from cancer. That's one area. So the work I've done is demonstrated how effective the screening tests are or are not in what particular patients and in what parts of the body. The second part of that work, which is really pivotal, is that how do you deliver the screening test in an effective way so it gets to everyone? And in that area, for instance, we've shown, salient to our earlier conversation, that we need to ensure that when you screen positive, you need to get a follow-on test. I'm really excited that this has become a national area of focus because up to today, or more recently, we've screened people and said, great, we've screened you, you've gotten a screening rate is so and so. That is all well and good, but if you don't get them from that point to the care they need after the test has been done, all of that is for naught. And so it's become a very important area in which Medicare also changes policy and coverage approach to this that allows us now to be more effective at guiding and navigating people to the care that is needed to prevent and get cancer early.
I think that word navigation or navigator is important because you actually have people whose job is called navigators that do this, right?
That is correct. So people who are especially trained to guide people through the care process. And some of them are community health workers who, by their training and by their background, are more culturally aligned with the patient's background and able to also be an advocate for the patients in the setting of care so they get the right and most respectful care possible.
So why is it important to reach these underserved populations? It can be people of color in Columbus. It can be people in rural areas of Appalachia. It can be any group of people that don't get the services that other people with more resources get. So how does that save lives, reaching out to these people?
Oh, this is a really existential question. It's a crucial question. Much of the United States, let me start here. United States doesn't do as well compared to other industrialized countries because of our health indicators are not as good as it can be. And this is driven, for the most part, by social determinants of health. So people's education, where they live, whether you live in Appalachia, rural areas where we know that healthcare facilities are not easy to get by, or if you need care, you have to drive long distances, 3 hours or so to get to the best care possible.
And take off work where you can't afford to do that.
Yes, or even if you live in Columbus, you don't take those things for granted. If you don't have the resources to hop on a transportation your neighbor is not safe, so you can exercise. So all of these things compound in groups of people who are socioeconomically underserved or disadvantaged, and that may mean Black people in our inner city areas. It may mean people in Appalachia, in rural farming communities, who, despite all of the richness of the land, have poor access to services. And so we in the United States and here in Wexner and the James have made a commitment to improve health of all people, right? And to do so, we have to be able to get people through these barriers and obstacles that are in the way. And we know we can do it, and that's where navigators can come in, and we can provide transportation to support people. And when they're food insecure, which has many ramifications, right? We can work with our partners in the community who have done this work for many years to help support those needs. Because in many ways, and we know with certainty, the best opportunity we have to improve health is before people get to us at the hospitals. When they get to us, some damage has been done that could have been prevented. And so what we've done and are doing is to partner with our community providers and partners to work together. This is part of our role and part of what we're doing that I talked about. We do the screening to identify areas of need. We provide the care, medical care that is needed. We provide navigation to people, and we ensure that our care that we provide is culturally appropriate, right? We provide culturally sensitive or competent care. And when needs are identified, we work with our community partners to ensure that people get to the resources that they need. For the most part, I will tell you that when we identify these needs, many of them already have a relationship with the partners to whom we're referring to. So that tells you the level of expertise that exists in the community. And so part of my privilege and my role in the Wexner wide role is to create these processes that allow us to do this with better fidelity. In the James, this is another important part. In my PED of Plan to Enhance Diversity role in Comprehensive Cancer Center, my role is to work with the leaders to increase the workforce, right? And I will say to you that one of the new opportunities we have is to create an Appalachian Health Equity Fellowship to develop workforce within the Appalachian area. And I'm working with others like Dr. Andy Thomas to try to increase capacity in our rural areas to
Meaning
provide
more
care.
doctors and equipment?
Doctors, workers, healthcare workers, and community leaders for that matter.
Okay.
Because it will take all of us to be successful at this.
Okay. We're going to take a quick break, and when
Let's
we
do that.
come back, we'll look at some specific programs that James is doing.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back, and let's dive in and talk about some of the specific current James programs that are out there in the community doing great things.
Thank you. That's an important area of focus for us in terms of cancer outreach and prevention. And so, as we spoke earlier, one of the important ways to address the barriers is to go to people where they are.
Right.
And which people where they are. And so I talk about just a few programs and focus on one of them in more detail. We have a mobile lung cancer screening van. We also have mammography vans that listeners may have heard about from Dr. Paskett and others. We also support a free colonoscopy program, and that basically does colonoscopies for free, right, by a group of volunteers within the Wexner Medical Center working with programs in the James to do so. And that's been very successful in screening people who would otherwise not have received cancer screening. And for our listeners, screening for colorectal cancer helps us to detect the cancers early when they are most treatable, and even prevent cancers from forming because it detects the polyps that are precancerous and remove them. So that's really important. So let me speak for just a second about an outreach program that we launched. Colon cancer screening in particular is an area of interest for me. And one of the tests, and there are many of these tests, a number of these tests, including Cologuard that people are aware of, that comes in the mail.
That's the one people can do it themselves at home.
Yes. Now let me talk about another one you can do at home, which is very simple to do. It's called a fecal immunochemical test.
Wait, say that again?
Fecal immunochemical test.
Okay.
For short, we call it FET, F-I-T. So the beauty of FET is this is a test that's been around, and it's one I've done a lot of research on, is that it's a small kit that we'll put in an envelope and we'll send to people at home. So in the comfort of home, you get this envelope, you do the tests, you just have a poop, stick it in the poop, put it back in a bottle, put your information on it the date of the test. When you completed it, put it back in the mail and send it to our lab here in Wexner Medical Center at the Dawn. And the lab will perform the test. And this test is one that's been shown or done nationally. In some of the systems, it's been shown to help improve the screening rate by a very high margin. So our initial focus in this pilot program we led, one was to replace the existing test, so we now have equipment in the lab to do it. And we then did a pilot, right, with my staff, where we send the kit to people directly. So far, we've reached 68 people who have returned the test and completed the test. And we rolled it out across our clinics, and we've completed, I think, getting close to 400 tests that have been completed. And when they're positive, we'll help put in the referral and get them to colonoscopy. And we're working with the colonoscopy program to ensure that there's access for these people when they get a positive test. So this is a test that in the future, our hope and aspiration is to do a wider outreach to reach more people, so we can directly send this to people who haven't been screened, as evident from our records. Even work with our partners to increase access to this test broadly, even beyond our walls at Wexner Medical Center.
So, okay, so you're at the very beginning and you hope to expand it exponentially and reach more and more people throughout Columbus.
That's the aspiration, yes.
Wow.
The work on the back end that is important is to ensure that, one, if they got the test or it gets returned to us, if they received it and haven't completed it, then we remind them through messages and direct phone calls. So that is probably the biggest part of the work. And our hope is to automate some of these processes so that the human element to it is minimized and to make it more efficient to deliver.
What else in the area of cancer screening is going on at the James?
So this is being a very important area. Cancer screening is seeing so much activity in the last, 5 years. I became involved in some of this work when I was working nationally on the U.S. Preventive Services Task Force in collaboration with the FDA, the Food and Drug Administration. It's a new novel group of tests called circulating tumor DNA. And basically what it is that researchers and industry have found ways to use what is called liquid biopsy, in which you take the blood sample and detect signals of cancer in the blood by simple blood tests. And through that process and the work that many have done, many companies, individuals, and institutions have done, found ways to even tell you where that signal for potential cancer could be coming from.
Oh, not only that you have it, but where in the body?
Where in the body.
Wow.
It could be colon, it could be pancreas, it could be lung, it could be ovary. And so I think that has been transformative in many ways, in that you can do a single blood test. And in many of these tests that are being developed, you can use a single blood test with the new technologies to be able to identify cancer in terms of where it is coming from, which means that if I know you have a cancer signal, with that blood test, I can say, well, this could be coming from the ovary, this could be coming from the kidneys, or coming from the pancreas or the colon. So what that is called a multi-cancer detection or early detection test, or MCED. An example of a brand name is the Gallery test that many people are familiar, because the company has marketed this fairly aggressively to people and to companies. And we at Wexner now offer that test to people. So that's one area that's very interesting. Parenthetically, I should also share with our listeners that the same technology in some companies have been used to just focus on one cancer. A good example is a new test that's been developed to screen for colorectal cancer. There are two companies at the forefront of this, and one of them is gone before the FDA for approval of this test.
Wow. So would that be for everyone, or for people who are at high risk due to family history or things like that?
So for the colorectal cancer one, I think we have a much better idea of who we'll be focusing on for screening, because we have guidelines in terms of who is eligible, who should be screened, not who should be screened for that cancer. So in particular case, if it's approved and endorsed by the guideline committees, I would imagine that it'd be for people who are about 45 years of age to about 85, or more routinely to 75. So this is average risk people. Now, because of the way these tests are designed, I would imagine and believe that the application of the test beyond the routine screening environment can go beyond people who are at so-called average risk. So it could be used for people who are at high risk. And I will tell you, my personal professional opinion is that these tests are best used in people who have either had cancer or could have recurrence of cancer, because they can detect these signals in the blood to help guide treatments and other therapies.
Okay. So circulating tumor DNA keeps coming up from you and everyone. It's across the board. I have a feeling that if we had 15 years ago, if I was doing this podcast, immunotherapy would have kept coming up, and now it's everywhere, and that 5, 10, 15 years from now, circulating tumor DNA is going to be huge.
It could be huge, and my assessment of the technology is that it will continue to have applications in the care of cancer patients. Now, the role in cancer screening, cancer screening, is a little bit less certain, especially for the so-called multi-cancer detection test. And the reason for that is that the current evidence or studies are not there, or haven't gotten to the point to tell us whether they are actually effective at detecting cancers when they can be most effectively treated, or even the precancerous conditions that we can identify to prevent cancer through screening. Yeah. Because cancer screening is done more than, when you think about cancer screening, the earlier concept is you detect the cancer before it causes any problems or symptoms. Now we've actually moved to a place where cancer screening itself can prevent cancer. A good example is colorectal cancer, cervical cancer. Lung cancer and breast cancers are still cancers in which we're detecting cancers mostly at an early stage, but still that allows you to prevent cancers. The challenge with the current evidence we've gotten from this liquid biopsy technology is that they are better at detecting cancer at later stages. So remember we talked about the fact that you can use them to detect signals of cancer in patients who have cancer, right? Especially cancer that's probably spread, because it will also be in the blood. So they're actually better at detecting cancers that are spread. In that scenario, it's close to 100% they detect the cancer in the blood. But in earlier cancers, that the ones we're looking to detect to help prevent spread, they're not as good. Yet. And the sensitivity is not as good. Yet is a good word. And my hope is the technology gets to a point where it can be tuned to detect those earlier cancers accurately to allow us to use them in a meaningful way.
Thanks for that great overview, and to reinforce the importance of screening and reaching out to underserved communities, which is a big mission of the James. So I'm always curious, what made you go do what you do, and particularly put such an emphasis on reaching out to people who need extra help? Where does that come from, and what motivates you to do that?
That's a question that's near and dear to my heart. And let me see if I can try to explain it in a short, brief snippet. I believe that everyone deserves the right and opportunity to get the best care possible. And I believe that people who have socioeconomic and other barriers need not be prevented from getting that care because of those barriers. Unfortunately, our systems are not designed to support people with barriers or obstacles to care. And many times are not incentivized, nor are payment structures designed to help our systems do so well. My hope and belief and aspiration is that we'll be able to, as a community, demonstrate that it actually saves money, saves lives, when we design our care processes and our community partnerships in a way to provide the best care possible to everyone who needs it, irrespective of a social and economic background. For instance, if only we were able to prevent someone from coming back to the hospital after they've been admitted into our hospitals because of social barriers are coming back, it only saves money, allows people to stay at home with their families as opposed to coming back to the hospital. So that's the reason why I do what I do. Plus, I was born and raised in a remote rural area where healthcare was a very distant dream. And so doing this work gives me a lot of career satisfaction. And there's nothing that makes me wake up in the morning than the dream and the hope that someday we'll get to that aspiration that I spoke about.
Well, every success story starts with a dream, right?
It does. And sometimes the miracles happen in small little increments.
Yes.
And I take them in whatever size they come.
One patient at a time.
And one little small change or improvement at a time. Even if I get someone to believe that this can be done or lean in to help support the work, including philanthropy and everyone at the Wexner Medical Center, because all of us at the James and Wexner are very motivated by our land grant mission. And that mission is to ensure that everyone in Ohio has the best care possible. And our state's health indicators are better than what they are.
Okay.
And thank you for having me.
Well, thank you for being here and sharing that and giving us hopefully a good map to the future and how things can get better and we can take care of more people.
Yes, we can.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.